Okay, I think this is a slide we left on before last time. We're talking about treatment of instability, and we talked about the different groups depending upon whether it's on track, off track, and whether the percent involvement of the bony Bankart fracture was less than or greater than a certain percentage. And I just want to remind you that we're going to talk now about the surgeries. And in between the last talk we had on this and today, we also had a lecture from the surgeons concerning this, the Curlin Joe Fellows in their program. And I just want to show in a minute the bottom line of that particular talk. We'll talk about what lateral J and Bristow is soon and some of the other things, but I just also want to talk about that if the patient has a lot of degenerative disease, so we're typically not now talking about young athletes, but older individuals, then we kind of ended up saying that often it's best not to do a lateral J or Bristow, but instead do an actual bone grafting to the anterior glenoid because it makes shoulder replacement a lot easier. If you do a lateral J or Bristow, which we'll talk about in a minute, it makes shoulder replacement much more difficult. So the state of, in older individuals, the state of the articular cartilage is important in determining what kind of a bony stability procedure you want to do. So this is basically the summary slides from our recent lecture from the Curlin-Jobe lecture program. They say now the bulk of the literature supports using a glenoid bone loss percentage of 13.5% in athletes to differentiate between whether you want to do a bony procedure or just soft tissue procedures to stabilize the shoulder. And then if you have an off-track lesion, then just a soft tissue Bankart repair, which is a repair of the anterior labrum, is not going to be sufficient. So if you have an off-track lesion, you have to do a more extensive procedure than just doing a labral repair. And then if the glenoid bone loss is greater than 20 to 25% in everyone, or if you have an off-track lesion, then a bone transfer is recommended. In younger individuals and in older individuals with degenerative disease, then you might want to think about bone grafting and not a coracoid transplant. So in this particular slide, this would be the percent glenoid bone loss. There are still some people who treat professional athletes who like to bring this percentage down to around 10% rather than 13.5%, but the studies in the literature support 13.5%. If it's an on-track lesion, then you do an arthroscopic Bankart repair, which is basically suture anchor repair of the anterior labral tear. If it's an off-track lesion, then they recommend an arthroscopic Bankart repair plus a possible remplissage, and we'll talk about what that is in a minute, or an open capsular shift and a possible bony lateral J. If it's in this intermediate zone, then typically you require a more extensive surgery. And then if it's greater than 25% bone loss, then a lateral J, or if it's large enough, this would be in a younger athlete. In older people would be a bone graft procedure to that anterior glenoid. So, Robert, what do you think of this patient?
So it's a 14-year-old baseball pitcher with pain after a throwing injury. Looks like there's extensive edema in the posterior lateral humeral head, also a little bit anteriorly as well. Subscap, I think, looks okay. Not seeing much else. that the middle glenohumeral ligament there?
Okay. Notice how it's thickened and kind of frayed here. Going down. Coming back here, looking at the labrum here. Labrum doesn't look too bad. I don't see a displaced labral tear.
Um,
Here's the sagittal image. What do you see on the sagittal images?
the seeing it looks like a thickened uh,
Kind of,
middle
kind
humeral
of a
ligament.
thickened middle glenohumeral ligament coming down here. And this patient ended up having sprains of the middle glenohumeral ligament and inferior glenohumeral ligament uh, as well. And that had a superior insertion of the anterior band in that patient as well. Okay, Tayson?
Right. 15-year-old male, shoulder injury, rugby tackle. Guess there is some edema of the infraspinatus muscle and
Okay.
a
Well,
little
we
bit of
certainly have fluid going here in the soft tissue plane between the infraspinatus and the posterior deltoid.
there's a little,
Maybe some edema in
yeah,
here.
and then anteriorly as well. I think there's
Here
some
we
capsular
see
edema
more
anteriorly.
imaging. And now maybe some in the muscle itself, right?
Yeah.
And then what did you say?
Posterior capsule. Is there a
Yeah.
little defect right there?
Looks like there may be a little bit of a defect there.
Okay.
It's more prominent as we get to this location, coming down here. So what do you think is going on here?
Capsular sprain and tear
Yeah.
posteriorly.
So this is called a reverse Hegel. This is an avulsion of the posterior band of the inferior glenohumeral ligament from the humerus. So it's a reverse Hegel lesion.
That procedure is much easier to do open with a small incision. Most orthopods will do it open rather than arthroscopically, repairing the avulsion from the neck of the humerus.
Thanks, John.
Okay, so here, axial view. I don't see
So
very
here's
much.
a T1, here's a PD fat set. What do you think is going on right in that area?
Well, I mean, we're above the equator. I think that the more anterior structure is the middle glenohumeral ligament.
Okay. Here's another cut.
Um, okay, maybe there's some,
further down.
yeah, there's some separation in that structure.
Yeah. Also notice here that the labrum looks fine on the PD fat set.
Mm.
If you look on the T1, it's actually an ossified anterior labrum.
Yes.
So we're probably dealing with an older individual here. Okay, and what do you see coming farther down? See a separation here.
Mm-hmm.
Maybe we're getting down to where there's a labrum.
Mm-hmm.
So what are those two things?
Could it be the middle glenohumeral ligament that's possibly torn? So,
Maybe the labrum there.
okay.
Okay. If we go farther down, what does it look like now?
So again, we see ossification uh, at that anterior labrum. Um, then we see that structure.
It's probably going to be the middle glenohumeral ligament coming and fusing to the deep subscap, and then that's the labrum. And so this was an anterior labral tear and had a lot of labral ossification.
Okay.
So, but this, yeah. Okay.
So T1 and PD coronal views. Kind of see some. See edema extending from like the greater tuberosity to
Okay. So Where would you describe? So this is probably the infraspinatus coming around here. So we're posterior superior, but we're very anterior here, right? You go to
Okay.
the images, this is what it looks like.
Okay. So kind of like superolateral or
But
like
further down, we have it here.
um,
Okay. So what are you concerned about? Let's see, let's go back. Oops.
maybe like an avulsion of the supraspinatus tendon.
The history here is this patient had a recent injury, shoulder injury. Oops. Wrong patient. Patient had a recent injury. So what do you think the injury was?
Um, I mean, it could be like a dislocation.
Yeah, so this patient probably had a dislocation. In
Yeah.
this case, the Hill Sachs is very superior.
Okay.
So this is probably more of an inferior dislocation,
Okay.
which is a little bit less common. And then what else do you see here on this image concerning the labrum?
Looks like there's a possible see some like splitting posteriorly, and then
One,
some like kind of fraying posteriorly, but anteriorly as well. There's like a probable tear in that labrum.
okay. So if we look here,
Yeah.
you can see that there is a tear of the anterior labrum, some injury to the anterior labrum there, and the periosteal attachment is intact. So we call this a Perthes lesion. So you have an anterior Perthes lesion, and we have an acute Hill Sachs. This is pretty much the typical location where we see labral tears and anterior dislocations. So this is an anterior, and if you look far, this tear went inferiorly as well. So this was more of an anterior and more inferior than usual dislocation, where we have a Bankart lesion, a soft tissue Bankart lesion here, and a superior Hill Sachs. Okay. Robert, what do you think of this case?
Let's see. Looks like there's a tear of the anterior labrum at the base with
Okay, so this is on 4/5/2004, and now the patient came back a month later, and this is what it looks like.
yeah, so looking at that anterior labrum, it looks kind of thickened and scarred.
Yeah. So this is a Perthes lesion with the periosteal attachment intact. I don't really think it's important to say whether it's a Perthes lesion or not. You treat it the same whether there's the periosteal attachments intact or not. But I just want to show you here how rapidly you can get that healing effect with thickening of the tendon. This occurred in 5 weeks. So when we say you see a thickened tendon or ligament, or in this case periosteal attachment, and it's thickened compounded with an old injury, that old may not be that old. This healing effect occurs pretty rapidly, but we can see markedly thickening just in a 5-week time period. Okay, Tayson.
All right, so we're looking at the anterior, inferior glenoid and labrum, which looks like is there some stripping of the periosteum there?
Well, what do you see here?
That looks like displaced labrum and some.
Okay, so this is a labral tear.
Yeah.
Maybe there's a little thickening of that periosteal attachment. And this is the Abra view. Where's the tear here?
Yeah, it looks like there's a little cleft inferiorly right there.
Yeah, right here.
Yeah.
Okay. So that's a Perthes. And we can see on the regular study, and this is the Abra study. Right. And you can see the thickening of the periosteal attachment. Yeah, John?
You have to remember when there's a dislocation, what you're looking at now is after reduction. During the dislocation, that tissue is peeled back quite a ways. I shouldn't say back, but anteriorly. And then as the reduction occurs, that's put back in, more in place where it should belong. But quite frequently, as we can tell, a lot of these do not go back to where they belong. They just stay hanging out there. But they were out there a lot further right after the dislocation.
Thanks, John.
Okay, 17-year-old, multiple dislocations. There's irregularity of the posterior labrum. Looks like maybe it's uh, dislocated medially, maybe.
You're talking about this?
Yeah.
I mean, posteriorly,
Okay. And then what do you think of the anterior labrum?
I think it looks fine.
Okay. Here's the ABR view.
ABR view, we see tear of the anterior labrum.
Yeah.
Yeah.
The posterior is kind of blunted here. Maybe it's a little bit thickened. We'll talk about the differential for this later.
Okay.
So this just shows you can occasionally you can only see it on the is on the ABR view. And, you know, again, as I said before, we don't routinely do the ABR view anymore because we found there are very few that actually you could only see on the ABR view, and we actually had more that you couldn't see it very well in the ABR view, but you could on the regular view than we had the other way around. But this is classically what you're looking for.
what's interesting is that you're using dye and it's not helping you much.
Well, here we really don't see the anterior labral tear with the contrast, but when we go to the ABR view, we do. You're probably right. We would probably see this just fine with joint fluid, not putting in contrast, if we did the ABR view without putting contrast in. But I don't know anyone who's done any studies just using the ABR view without arthrography.
So I think looks like there's edema throughout the visualized humeral head.
I can't hear you.
There's edema throughout the humeral head, or no?
No, I don't think so.
Okay. Um,
This is a T1 weighted image,
oh, okay.
and this is an arthrogram.
Okay. So there's that thickening surrounding that anterior labrum.
Okay, so what is that? This is on the T1 weighted image. If we go to the PD FATSAT image, it looks like that.
So it looks like possibly like some sort of cystic lesion.
Okay.
And
What cystic lesion would you think about in that location?
it could be like lifting of the periosteal region,
Well, but what would lift it up?
like a
Could it be a cyst?
yeah. I'm not okay.
So this is a non-communicating paralabral cyst. Paralabral cysts almost always mean that you have a labral tear there. So this is an anterior labral tear with a cyst, but notice that these cysts do not always communicate with the joint space. In fact, they often close up, and this is more of a gelatin structure typically rather than a fluid structure, even though it looks fluid on the fluid sensitive images. But this would be a paralabral cyst. The contrast we don't see going into it. So again, you don't really see the labrum very well here, but you can, it's pretty much surmised that there is a tear there because of the presence of the paralabral cyst.
Well, in this case, using contrast makes it more difficult to read.
Yeah.
What do you think, John?
Well, I mean, we're just used to knowing what these look like now, but you're right. I think it can be confusing, which is the reason I included this case so that the fellows would see it. You're right. Okay. Robert.
So we have a 20-year-old labral tear. Posterior labrum, I think looks okay. The anterior labrum, I think, is a little bit blunted.
Okay.
Discrete tear.
Okay. So why do you think it's blunted?
Uh, there's probably been some sort of trauma, maybe a prior dislocation.
I'm sorry, say that again.
Said there's probably been some sort of trauma, maybe a prior dislocation.
Okay, maybe. What do you think this thing is?
Um, is that maybe a piece of the labrum?
Okay, right. And then we can see that there actually is a Hill-Sachs in this case. So you're right, this patient had an anterior dislocation. This is a displaced anterior labral tear, and it's not uncommon for these tears to break off, displace, and then adheres to the anterior aspect of the glenoid in this location. We can see there's a little bony injury here as well. And it's important to recognize this as a displaced labral tear, because then what the surgeon will need to do if they go in there and want to repair this, they have to free this up, and it's usually fibrous down and difficult to see arthroscopically unless you know it's there. Move it back into the proper position, and then you suture it in with suture anchors. So it's important to recognize that when you see it on an MR examination.
All right. So anterior, inferior glenoid, looks like there's some cartilage and labral injury, and there is a kind of more balled up piece of fibrous tissue, yeah, more medially.
Okay.
Um,
Yeah,
is
there's
that
a
just more
name for
displaced?
this. Yeah, so this is again a displaced tear. This is called an Alpsleeve, an anterior periosteal sleeve avulsion lesion. And the same as I said before, you need to describe this, give its location, because if they operate on this, they're going to need to free this up and put it in proper location to repair it. Okay, here's another Alpsa lesion here. See all that thickening of the uh, periosteal attachment in this particular patient. Okay. Yeah, this was a athlete.
Mhm. Okay, so PD fat set images, anterior labrum. Again, we see this kind of this tissue medial to the anterior glenoid. I mean, could be displaced labral tissue.
Okay, so this is on 42107, which we see there, and here's your Hill-Sachs lesion.
Mm-hmm.
Okay, now this is later. Now, actually, I saw this in the reverse order. I saw this one first, and the other one was done somewhere else.
Mm-hmm.
So now, so this is the prior study done in 2007, and now the patient came back in 2008, 11 months later.
Right. So along the anterior glenoid, we see thickened tissue. It looks like, again, a displaced labrum, but more tacked down.
Right. And this patient actually went to surgery. The surgeon found the labrum sitting in this location, freed it up, and repaired it. But I don't have any post-repair images on this particular patient. So just recognize this as actually a potentially displaced labral tear that might have to be freed up and repaired at the time of surgery. Okay.
When you put that back, you have to tighten the capsule also,
Okay, thanks, John.
because that piece of tissue carries the capsule with it.
So it looks like again we have a disruption of that lateral part of the anterior labrum, and then some like tissue in the kind of medial to the anterior glenoid as well.
So what do you think's going on right there?
But that's probably a tear there. Or
To what? Of what?
What's the word?
I think anterior labrum.
Okay. Now this is cartilage across here.
So chondral defects.
So this is actually a tear of the articular cartilage.
Okay.
This patient had an anterior dislocation. There's actually, if you look here, you've got to have another Alpsel type lesion. And this is disruption of the articular cartilage. This is called a GLAD lesion, glenoid labral articular disruption. Some people love these terms. I prefer just to recognize what it is and describe what it is as a
It's a little bit
tear of the
of
articular
like a
cartilage.
um,
Yeah, so this is
displaced piece of cartilage.
yeah, yeah. So
Or delamination probably would be
right,
the best word.
yeah. So this is a tear of the anterior glenoid. You need to measure what you think the size is, and it's a delamination undermining the labrum. So when they go in, what's important is the size of the tear back to where you have normal cartilage, because if they're going to repair this, they have to debride all the unstable fragments typically in these patients. There are
Do you
sometimes
think there's a
tack
piece
it
of,
back down. Yeah.
John, do you think there's a piece of tissue glenoid there in that recess down below?
Down here?
Yeah.
Yeah, I think so. And I think there is also some periosteal thickening and some displacement of the labrum
Yeah.
here too.
And it always is worse when before reduction. That's why it leaves the stuff behind. You got to look for it.
Thanks. Robert.
All right. So this one looks like there's a tear of the anterior labrum, and it looks again like there's disruption of that articular cartilage.
Right. So this is another anterior labral tear with a glad lesion, and the periosteal attachment is still intact. Okay.
All right, so there is some attenuation of that anterior inferior labrum. I think the tissue is displaced.
Okay. So this patient had an anterior dislocation, maybe a little bit of signal here. It's not as black as you would like. The cartilage looks pretty good. So this is on 3505.
Okay.
So the patient was scanned a couple of months later, and this is what it looked like.
So there was some sort of a cartilage injury there along with the labrum, and it healed back
Probably
down.
that we didn't see here. At this point, we don't see a bone injury, but 2 months later, without an intervening trauma that we know about, he now has a lot of subchondral cystic change here and probably disruption of the articular cartilage and the labrum. So these what we usually think of as degenerative changes can actually occur pretty rapidly after these traumas.
Okay, so this is an axial T1 arthrogram. There might be a cartilage defect anteriorly.
Okay, so right there.
Yeah.
Now, the one thing here that we'll talk about well, maybe, anyway, I think maybe we already have, is that the actual glenoid is abnormal here too. The posterior glenoid rim is very blunted.
Yeah.
The posterior labrum is very blunted. We'll talk about this when we get to the posterior labral tears. And there's kind of underdevelopment of the posterior glenoid rim. And then here on the coronal images, we can also see that delaminated tear of the articular cartilage. Okay.
So axial T1 and then PD. See a lot of just diffuse thickening of the anterior labrum most prominently, and then that posterior aspect might be a little bit blunted as well.
Maybe a little bit blunted, yeah. And so what do you think's going on out here?
Um, the labrum likely tore and then was displaced anteriorly, and then there's probably some scarring down.
So you think this is the labrum here?
Yeah.
What's this high signal intensity in
Mm.
it?
Oh,
Image.
it could be a osseous fragment.
If we go to the sagittal images, this is what that high signal looks like.
Hmm.
And this is a labral ossicle.
Oh, okay.
Looks like bone.
Yeah, it is bone, I think. I think these occur from trauma, and then over time, these can, you can probably get, well, these areas of trauma can heal with ossification, just like we've seen in other areas. These are really pretty rare, especially ones of this size. But just remember, you can get ossicles within the labrum, which is probably post-traumatic. Robert.
All right, so we have a 41-year-old female with pain and aching for 5 months. Let's see, maybe a little bit of irregularity of that anterior labrum, but
Okay.
don't see anything for sure.
8/22/2013. There's another image. Here's another image back here.
Some, yes.
And
There's
a little bit of regularity here. This is the sagittal. Okay. So this was called an anterior labral tear.
Yeah,
Okay. Right here.
I see.
And then there's a concern of possible Hill-Sachs back here. As you can see, that's not a classic Hill-Sachs lesion, where sometimes you can just get abrasions, which this could be a Hill-Sachs abrasion. Okay, so this was called an anterior labral tear. Now the patient came back 3 months later, and here's an arthrogram. Let me show you that one. Let me show you this one. Let me show you this one, this one, this one, this one. And here's some other images.
Honestly, the labrum looks fine.
Okay. So the question then is, what is this structure?
Yeah.
And forget that structure. If we go here, okay, and then here, so here's the arthrogram. So we go here, we've got this funny structure here. We've got this funny appearance here, which I think you remember, I think I showed an example that looked like this on a potential #1 NFL draft pick. And then here, now we've got 1, 2, 3 little things here. We have to figure out what they are. And then the next cut up, we have this structure here, and this is the superior glenohumeral ligament. This balled up structure here is a combination of where the superior glenohumeral ligament, the anterior superior labrum, the middle glenohumeral ligament, and occasionally a superior insertion of the anterior band of the inferior glenohumeral ligament can all come together in one location.
Okay.
And this here. And if we go to the sagittal images, they can actually be helpful here because this really looks like the middle glenohumeral ligament here. That's this structure. Then there's another structure behind it if we go through all the cuts. And this is actually a superior insertion of the inferior glenohumeral ligament and is all normal anatomy. So if we go back again, that can be deceiving. The anterior and posterior horn look the same. If you put this down, it could be a large anterior horn. I would be concerned about the possibility that that could be a labral tear, but then you've got to follow the anatomy. And we don't see it here, but if you follow that thing up all the way, it comes to here. the labrum itself peters out like it should be in the anterior superior area. So if you follow it, it goes more like a anterior band of the inferior glenohumeral ligament than with the arthrogram to further determine whether there was a tear or not. This is probably the labrum coming right up to the edge of the glenoid. This is probably that anterior band of the inferior glenohumeral ligament, maybe a little middle glenohumeral ligament starting there. If we come up here, that's labrum. This is that anterior band of the inferior glenohumeral ligament that's going to be superiorly insertion. This looks very similar to that football player that I showed up here. This is very irregular. Be concerned about it, but this is middle glenohumeral ligament, anterior band of the inferior glenohumeral ligament, and labrum. So this is a normal anatomy, and the middle glenohumeral ligament and the anterior band of the inferior glenohumeral ligament all come up here where they fuse with the superior glenohumeral ligament. So, and then we can see
And the locations of the ligaments can vary quite a bit, can they, John?
They can. That's right. Okay.
And it's pretty unusual. Well, not unusual, but it's not common to see that in women on this location,
Okay.
unless they have a husband that beats them.
All right. 43-year-old male rule out subscapularis tendon tear. The subscapularis is a little bit of attenuation, the deep fibers, but I don't think there's a tear.
Okay.
I think our round structure there is maybe middle glenohumeral ligament, or maybe anterior.
Here's this cut. Here's the next cut up.
All right, there is some.
Another cut up. I mean, down. Sorry. Another cut down. So what's that structure right there? If we go to the sagittal images, this is what it looks like. So what's this thickened area of increased signal intensity there?
Is it IGHL? That's my best
Okay.
guess.
It's actually a torn superior insertion of the anterior band of the inferior glenohumeral ligament. I think it's the only one of these that I've seen that's been arthroscopically proven.
Oh.
Okay, so now let's talk about kind of surgical changes. So a Bankart repair is where you repair the torn anterior inferior labrum. So here the Bankart lesion is the tear of the labrum from the bone here due to the shearing forces in the anterior dislocation. You put in suture anchors, typically 3, but I've seen up to 11, and tie it back down in place. Try to get bleeding of the bones so that you get soft tissue or the bone healing to the soft tissue to make it a stable repair. This is an old study. Go ahead, John.
One thing about the Bankart repair, it's easier to do arthroscopically than open. That's one of the few procedures that's easier to do.
Okay.
Because to do it open, to get down in that area is it's a mess. It's very, very hard to do. Murphy, who was supposed to be one of our best known shoulder surgeons, came to UCLA, and unfortunately I wasn't there. I was putting on a cast or something, and my mentor was assistant Murphy to do this procedure, and he said, "Oh, it'll take me 45 minutes." Well, 3 hours later, the 45 minutes have long gone. And we stopped doing the Bankart. I never did one.
Okay. And then this is an old MR study, and you can see the suture anchor placements here, anteriorly and inferiorly in this picture. These are the old suture anchors that are metal with a lot of metal artifact. Fortunately, they don't use these anymore. And there you can see the suture anchor placement of the Bankart in this old arthrogram. So here's another example. Here you have multiple suture anchors. This is a little bit different injury in that you have both a superior and an anterior labral repair here. And if you can see here, this is actually a suture anchor right in that area where we commonly will have a sublabral foramen. And generally, surgeons now try to stay away from this particular area because if you repair something that's not really a tear, you can overconstrain the shoulder. So typically, you kind of stay away from this particular area.
That's pretty high.
That's very high, you're right. And here we can see there's also a tear down here below where there's not a suture anchor. Okay. And here's just another example of a suture anchor and repair. In this particular case, you can still see that there's fluid involving the labrum. This is below the area of the suture anchor. This is more of a superior suture anchor. Oh, I'm sorry, no, this is inferior. Sorry about that. We can see it extending superiorly there, that tear. And that was a recurrent tear after suture anchor replacement. Let me see, who's next? What do you think about this one?
Okay, so coronal PD fat set. We see what looks like suture anchors in the glenoid.
Okay.
Okay, there's this structure inferiorly. Could it be labrum that's displaced?
Are they in the right place?
They seemed pretty superior.
Yeah.
Yeah.
These are very superior.
Yeah, they sure are.
And there you can see the displaced labral tear down there. In the axial images, you can see it's a displaced labral tear. Looks like the periosteum is still here, but you got a macerated displaced labrum here.
That didn't help this patient.
Okay. Hold on.
Wait, was it back in place when they did a repair?
This is after the repair. Here are the suture anchors. This
Yeah.
is post repair. So this is actually thought to be a re-tear after the surgery.
Uh,
Okay.
Bristol. But with two holes there, that doesn't make it like a Bristol.
Yeah, these are suture.
Bristol only uses with one screw.
And these are too high for a Bristol, right? These are suture anchors from a label.
Ladder jet uses two. Bristol uses one.
Right. But not in this location.
So it looks like current is. I'm not sure exactly what's going on here. Could it? I mean,
Okay.
those probably shouldn't be a pad. Like,
These are suture anchors,
uh-huh.
but the injury is down here. These suture anchors are pretty high up.
Okay.
So you can see the flattening. This is a bony Bankart injury down here. Right?
Okay.
So nowadays, this is before we had the current concepts.
That's not an open coracoid transfer, I don't think, is it, John?
No, this is a arthroscopic labral repair, and now
Yeah.
the question is to the radiologist: should they go back and do another arthroscopic repair, or should they do an open surgery and basically do a Bristow procedure? So that's the question.
Oh, the question is, okay, I got it now.
So, Pavan, what are you going to tell the surgeon to do?
I would do a Bristol. That's
Let's ask Pavan what he would do.
it's not unusual at all in sports to have a bank card fall apart. Just if you do the same thing that you did with the initial injury, the same thing will happen with the bank card. If you put a bone in there like the Bristol procedure or the ladder jet, that's not going to happen.
Okay,
So
but let's ask Pavan what he would do, John.
So,
what I would do,
No, what Pavan would do. The resident, it's his case. Let's ask him what he would do.
so since this arthroscopic repair,
well, I would do a Bristol.
I would, I would do a
Just
I've never done a ladder jet.
Okay, so, okay, and here on the coronal images, what you can see is the capsule is really displaced here. In fact, you can actually see that there's probably a little piece of bone. This is probably the Bankart that's displaced. It may or may not be attached here to the glenoid in a displaced position. I can see it around there. This bone should be over here. It's displaced. On the axial images, you can see the defect in the anterior inferior glenoid in that location, and the patient ended up having a bony Bankart repair, just like John said. Nowadays, what we would do is do a perfect circle. We'd determine the percent involvement of the bone, like we talked about in the last lecture. And we would also determine whether this is an on-track or off-track lesion, as we talked about the last lecture. And then that would then put us into the decision-making algorithm that we talked about at the end of last lecture and the beginning of this lecture. So that's what we do now. And back when we had this particular study, it was really before a lot of those papers came out. So in this particular case, the correct procedure was done, though now you guys know how you want to evaluate this and help the surgeon. Okay, Robert.
All right. So we have an 18-year-old status post Bankart repair 10 months ago, re-injury and rule out re-tear. I see a surgical anchor, kind of anterior glenoid. Looks like there's a defect where there should be bone and labrum.
Yeah, it looks like there's probably a bony defect here as well. So it looks like there's a bony Bankart, tear of the labrum, and displacement of that with a little bit of a thickened periosteum here in this
That's
location.
basically a fracture.
Right, so it's a Bankart fracture in that particular case and a re-tear. Here's another image where you can, in this particular case, you can see the displaced labral tear and the thickened periosteal attachment compatible with the Perthes lesion. And farther up, we can see the tear extends up. This could be up to the foramen, but we can see that there is a big displaced tear here and a Hill-Sachs lesion. And it extends all the way up to the superior labrum. Okay.
All right, 32-year-old male, left shoulder pain, loss of range of motion. So it looks like we have a Hill-Sachs defect. Then there's some injury to the anterior labrum and glenoid as well, right?
Okay.
Yeah.
And then this is a month later. No, this is 2 years before.
2 years before.
So look at this is a big defect.
Yeah.
And so right away, this is probably going to be an off-track lesion, right?
Yeah.
Okay. So this looks like a big off-track lesion. Now, this is what that Hill-Sachs looks like. And there's this funny thing here. A lot of that bone injury has healed in the interval.
Yeah.
I'm sorry. I'm sorry. We've got a new bone injury in 2017, but
Is that a
basically, what is
new little divot from a redislocation that's
let me show you
a
the
piece of
sagittal images.
labrum there?
Here are the sagittal images.
Yeah, so there was already a flattened contour on in 2015,
Right.
but
This is the
yeah,
hill sag.
definitely looks like there's
A
another
lot of synovial thickening here.
impact.
But now what's happened here?
Oh,
Okay.
are
So
these
what,
little
what
tracks?
what they did is that they basically put suture anchors in and to the posterior capsule here.
Oh, so remplissage
So
procedure?
this is a remplissage.
Okay.
And by doing that, you attach the capsule here, and that limits external rotation so that that Hill-Sachs lesion will not extend up to the edge of the glenoid. So this is what a remplissage looks like. So at the beginning of the lecture, I said that I was going to promise that I was going to talk about what a remplissage is, and this is what a remplissage looks like. And that's what it does. It limits it intentionally limits motion of the shoulder so that you don't engage the Hill-Sachs lesion.
It looks like the suture anchor is too high, but
Okay.
I'm here to criticize, John.
All right. We wouldn't know.
My job in life.
Okay. Okay.
Mm-hmm.
Well, we'll end on this case maybe.
Okay, so um we got the artifactual signal in the glenoid.
Okay. So it
No.
looks like there's a lot of metal there,
Mhm.
and it's right on the anterior, centered around the anterior glenoid. So what do you think this is due to?
Uh, a repair of that labrum, but I'm not sure.
This actually isn't a labral repair.
Okay.
So it looks like it's in the bone. You've got a big thing here. There's just one of them. This is a Bristol procedure.
Okay.
Okay. And that's a big screw that you put in, a single screw. John, do you want to tell us what a Bristol procedure is?
Bristol basically is you remove um, about a centimeter of the coracoid process with a conjoint tendon. After you split uh, the
Subscap.
subscapularis. Um, I used to do my own procedure, so I used to split it longitudinally, and then inferior third I would split transversely, so I could tighten it, and I would then drill the hole for the uh, for the screw to enter the bone in front of the glenoid. I mean, posterior medial to the glenoid. And I would also pre-drill the coracoid process before I removed it. And I also would put a screw in it. So that would make it much easier to put this, after you have the screw in a piece of coracoid, then you go down to where you made a drill hole from anterior to posterior in a glenoid, right adjacent to the uh, joint, and right at the level of the labrum, and then go from anterior to posterior, tightening um, the coracoid process that you removed after you debride all the cartilage, and go right down to bone, so that you have bone on bone, bone of the uh, coracoid process and a bone of the glenoid, and then you tighten the screw, and you're done. Um, then I used to imbricate the capsule and subscapularis muscle back in place, but a little tighter. And like I said, that became my favorite procedure. I did that on kids and adults, and I did my share. And I had one recurrence on a druggie that used to go surfing, and he had a very severe injury. besides that, he wound up in jail.
Okay. So this stabilizes the shoulder two ways. It takes the coracoid process and puts it right where you have that defect from the bony Bankart. So you augment the bone of the anterior inferior glenoid. And also
Well, I used to do it on everybody, John. I
okay,
didn't do a Bankart. I didn't do a Magnuson. I didn't do a
yeah.
Putty Plat. There are a whole bunch of procedures. I came to do the Bristol for everybody.
I'm just talking about the Bristow. I'm only talking about the
Yeah.
Bristow. And so you get a bony hypertrophy. You get augmentation of the bone there for stability, where the bone's been fractured. And then also by taking the conjoint tendon, remember, stays intact. You take the coracoid process from external to the subscap, you put it through a hole in the subscap, and the conjoint tendon goes with it. So you also have soft tissue stabilization of the anterior shoulder because of the transfer of where the tendons go. So
That's right. The tendon prevents it from dislocating also
yeah,
inferiorly because the tendon is inferior.
yeah. And then arthroscopically, you do the ladder J, which is basically very similar, except instead of putting the base of the coracoid into the glenoid, you turn the coracoid on its side and install it with two screws rather than a single screw.
Right. It's a lot harder to do because it's very slippery. And then to drill the holes in the bone is not easy. And then to get it aligned with a glenoid from anterior to posterior, it also makes it hard to do. So it's a much harder procedure. And when these two procedures were published, the Bristol was the one that was accepted in my day.
Yeah.
Nobody did the ladder J.
Right. Okay, so why don't we stop here and we'll pick up talking about some other injuries of the shoulder next week.
All right.
Have a good weekend, everybody.
Thank you.
Take